This is the Etiology podcast. I am your host, Elka Kubaku, licensed social worker and psychotherapist. In this podcast, we explore divisive issues around food, health, and body image with the goal of mending relationships within the eating disorder recovery professional community and creating a space where a multiplicity of perspectives can coexist harmoniously. This podcast is uncensored and encompasses the political and ideological spectrum. If you believe something you hear is harmful or misinformed, please be respectful to the speaker. And also, feel free to reach out about recording another episode on the same topic from your vantage point. My hope is that if, as professionals, we can hold each other's stories with respect and compassion, we'll be better able to do so for our clients.
Bariatric surgery is a medical procedure that modifies a person's stomach and sometimes intestines to help them lose weight. In the eating disorder recovery world, this topic isn't discussed often because so many professionals take an active stand against fat phobia and, by extension, intentional weight loss. Our guest today brings together two worlds that don't typically converge. She entered the field of bariatric psychology as an eating disorder professional. In our conversation, she shares her own lived experience of recovering from disordered eating through intuitive eating. She talks about her belief in rejecting dieting and her awareness of fat phobia and how it shows up across society and in the lives of the individuals she assesses. At the same time, she is part of the process for one of the more invasive weight loss procedures. You may be wondering why we're talking about weight loss surgery on a podcast focused on eating disorders. And I agree that there are settings like meal support groups, for example, where discussing this would very clearly be harmful. However, on this podcast, my goal is to create a space where nothing is unspeakable, where the human experience in all of its complexity is welcome, where people from different disciplines and ideologies can come together. I also enter this conversation with trust in you, the listener, to take care of yourself and feel free to skip any content that doesn't feel right for you. Alicia B., and we're using a pseudonym for reasons our guest will disclose on the podcast, is a clinical psychologist. She began her work as a clinician focused on eating disorders and disordered eating, and has her own history struggling with food, substances, body image, and emotion. As her professional life evolved, she became a bariatric psychologist who is passionate about her work and has helped over 1,800 patients on their weight loss surgery journeys. She works in private practice in a rural community where she is the only bariatric psychologist. She has published a chapter on bariatric psychological evaluations and presented at the annual meeting of the American Society of Metabolic and Bariatric Surgery. Hi, thanks so much for coming on today.
You're welcome. I'm glad to be here.
So, you are a bariatric psychologist.
That is correct.
The two movements that I'm balancing on this podcast are the first is that I want when people are engaging across differences or ideological divides in the eating disorder recovery community, I want to bring the human face back to that conversation. Meaning, when we're having conversations on social media, often we don't really see the person we're talking to, or we don't hear the story behind their position. So it's really easy to go on attack or to shut each other down. So I tend to go quite a bit more into the personal than you might on a more informational conversation. And then the complementary movement is in order to make it a safe place, I want to give people complete ownership of what they share with the world. So if somebody ever wants to cut something, I'll cut it, no questions asked. And same thing with your name is if there's a reason or if you're wanting to withhold that, I want to be able to move with that. And the way that I balance these two movements is that when there's something that someone doesn't want to go into or talk about, I like to understand the reason behind that so that even as we're maybe withholding a part of our story, we're also sharing something of ourselves in terms of the process of that withholding and what motivates it. Does that make sense?
Mhm. Mhm.
Can you tell me a little bit about why you're wanting to show up without your name on here?
Liability insurance wise, I'm sure my liability insurance company would not want me putting everything out there like I might today. Sometimes at work, people get really upset with me if I don't clear them for surgery. And sometimes there's some very difficult personalities that are involved, a little more litigious in nature, and maybe looking for anything that they may or can use against me. And so it is really a form of professional protection that, not like I think I'm going to share anything today that's going to put me at risk, but I do the best I can with what I do. And I really come to it with a caring heart and ethical place, and doesn't always get received that way. And I've had some horrific reviews on, mostly good reviews, but some horrific reviews on Google. And usually they're not even true. Maybe they're true in their minds, but they're not true. So that's why.
That's really interesting because you're in a place that is sort of at the intersection of the medical and mental health. And in some ways, you have a lot more, I don't know if power is the right word, but then let's say a therapist, where when I'm seeing someone, they're not really dependent on anything from me besides their emotional support and working through their own experience. Whereas for you, with you, they're coming to you hoping to get approved for surgery.
Yes, I'm a gatekeeper.
Yeah, you're a gatekeeper.
Yeah, I've done close to 1,800 of these evaluations, and I think I have said no maybe 4 times, but oftentimes I will say not yet. And it's the not yet that pisses people off. Sometimes. I mean, sometimes people act like they welcome it and they appreciate it and they want to follow through. Um, it's not always the case.
I want to understand more about what the surgery entails and then go into what your assessment process is and what you're looking at when you're telling someone yes, not yet, or in those 4 cases, no.
Okay.
So tell me a little bit about the what of bariatric surgery. When someone's getting bariatric surgery, what is actually being done? What's happening?
Well, there's different procedures. Some procedures are purely a restrictive procedure where back in the day they put a lap band in. They put a band around the stomach to make a small pouch, and that band could be expanded or contracted with fluid that was put in through a port. So it made this restriction. Over time, we came to learn that that procedure isn't offered anymore because surgeons are taking it out more than they're putting them in. Most surgeons won't even put them in because they didn't work out so well for many people. Right now, there's the vertical sleeve gastrectomy where a person's like 60 to 70% of their stomach is cut out and removed and stapled shut. And so they have a pouch the size of a banana. So that is restrictive. It just makes a smaller place for where the food can go. It also has some impact on hunger hormones. Um, so people might not experience as much hunger, or they'll experience fullness faster for the restrictive reasons. And then there are malabsorptive procedures that also create a pouch, a smaller pouch, like the size of an egg, and that's where the small intestine is cut and then reattached to the bottom of that pouch, bypassing where a lot of absorption comes into play. So people get full really fast on a very small amount. And then nutrients don't absorb as well. These folks have to be on nutritional supplements for the rest of their lives. And so what these procedures do is limit the amount a person can eat at one time.
Hearing you describe it, it sounds like a pretty invasive medical procedure. If somebody's entering to do this, they really want it, or there's something that feels really desperate about their situation.
Yes. And it's not something to be taken lightly. It is an elective surgery, but it is very invasive.
Can you describe to me some of what you see people coming in with? What is driving people to want this surgery?
For a lot of folks, it's improved health. they're getting to a point in their lives where their weight is affecting their health. When we're younger, or when folks are younger, they can weigh more and still maintain good health, but I think over time that the health can begin to deteriorate. And so oftentimes we're seeing people in their more in their 30s and 40s. So a lot of people want to get off or reduce taking medications, have better glucose control, have more energy, be able to play with the grandkids. I hear that a lot. And I think that is always in play. The health related factors are always in play. Many to being the fat kid, they're tired of the stigma that they experience, and they want to be someone in a smaller body and not experience the judgment, the discrimination. People get passed over for jobs because of their weight.
So what I hear you saying is part of it can be health as people get older and they're experiencing the health effects that have been associated with their weight. And the other part is fat phobia and weight stigma. And at a certain point, a person's just like, I want to be accepted for who I am. And that feels much easier in the world that we live in a smaller body.
Yes. And then there are folks who are still pretty young, and that they know if they continue on this trajectory, they're going to have health problems that run in their family. So they're wanting to do it earlier on to prevent those things from happening.
Do you see people after the procedure as well?
Not very often. It's very rare. And it might not be because it might be because I don't recognize them because they look different, but I don't see them in my office. I live in a small community, and I might see them in the grocery store. And if they say hello, I'll say hello back.
So you don't, in a professional context, though, get to see the after surgery, only the before.
Pretty much. Pretty much.
The question that I'm having, and I'm wondering what you see of this. I don't know how relevant it will be to you because you don't see people after, but I know in the eating disorder recovery world, the entire weight determines health has very much been challenged. And there is a lot of work, or a lot of people talk about correlation not being causation. So we might have conditions that are associated with higher weight, but not actually caused by those. And there's a really strong movement in terms of trying to dismantle that association and the frequency with which it's prescribed by doctors or medical providers as the answer. So I'm curious if at all, or if at any point in your life, if you've seen the after surgery and what that looks like for people and to what extent it fulfills what they were hoping for.
If I see someone after surgery, it's because they haven't done well and they're wanting a revision, and I have to evaluate them again. I have people in my social circle that have had surgery, and they're very happy with the outcome and wish they had done it sooner, and their life has changed. And when I meet with folks, I always ask them, when I meet with folks for an evaluation, I say, how many people do you know who've had bariatric surgery? And are those people that you would feel comfortable turning to for support? Because I'm trying to assess, the availability of support network and who may have walked down this path before them that they could turn to. And, I always hear, yeah, I know, but there's a mix of, well, I know, like some of them have done really well and some of them have not. Some of them have regained the weight, or some of them have a problem drinking, and some are doing great. So they want to turn to the people who are doing great. So, I hear about it.
There's a mixed bag in terms of results, which is true for lots of medical treatment. So from some people who you've encountered and maybe people who your clients have have done really well with it, and you also have some people coming back to you who haven't done so well and want to revise it. Can you tell me if you can pull together sort of the typical story that you hear in terms of both of those? When you see people who've done well, what do they talk about experiencing better? And when you see people who come to you and are like, this didn't work out to me, what does that story look like?
Well, the people who have done well have maintained much of their weight loss. Yeah, I think normal to have about a 10% regain of what you've lost. But the people who have done well are not necessarily the folks that didn't struggle, but they're the folks that may have struggled but reached out for help. And they kept course correcting and asking for help. And they're happy with how their lives have changed and how much better they feel and more energy, less pain, um, better libido, grew some self-esteem and left their husband who was a jerk or vice versa. So the second question is about asking about the folks who haven't done so well and they're wanting a revision.
Yeah, what does that look like?
I can honestly say that everyone who's come for revision to see me, their lack of progress or regain has not been a failure of the procedure. It's been because of their eating behaviors. They have not been following the post-surgical recommendations. So grazing is one of those things that people can get away with after surgery. That's why it's strongly discouraged, and one can consume a lot of food when they're grazing, eating calorie-dense foods. There's always been I wish I could report an exception, but it's always been caused by how the person is eating. So these procedures aren't foolproof. They don't work if the person doesn't work it.
When I hear that, to me, what it triggers is the willpower story when it comes to weight loss. And in what you're describing, I hear someone whose physiology was changed, but whatever it was that was maintaining their eating behaviors is still in place. And I start to wonder what that is. I do become a little bit afraid of, yeah, blaming the person or sort of the willpower story. How do you understand what is triggering people to continue eating in these ways when they're doing a pretty invasive procedure? This is something that they clearly really want, but there's something in them that's working against it.
When there's emotional eating, right? Emotional eating is serving a purpose. You know, it's helping the person in some way. It's helping them cope, whether it's with substance or a process, but it can be a coping mechanism. So if a person hasn't developed coping strategies or implemented those healthy alternative coping strategies, food is a go-to. And it's a go-to for many of us, no matter what our weight is. Um, the other thing is, I guess that comes back to coping strategies, but like if a person's struggling with their emotions, severe depression, severe anxiety, mental health comes into, has an impact on eating behaviors, self-soothing, don't care, one can get so depressed they don't care, feel hopeless. Oh, what's the point, right? I'm still fat, or, you know. Um, and then if someone has a history of sexual abuse victimization, as such a person loses weight, they they may feel more vulnerable and increase increased feelings of vulnerability, anxiety. I mean, there can be a part of them that is like saying, "Oh, hell no, you know, we gotta eat, we gotta keep this weight on, this doesn't feel safe. I'm not comfortable with this attention," because as people lose weight, people comment. They think they can comment. And that's really uncomfortable. And people don't know what to do with, patients don't know what to do with that. Yeah, there's a lot that underlies it that drives I don't like this word, but it's the only word I can think of, but the self sabotage. It's often unconscious. Mm. And my heart goes out to them.
Mhm. When you were talking about for many of us, food can be coping, I heard the first person in that, and I know the last time we spoke, you had mentioned that you had your own history with food behaviors, eating disorder, substance. Can you tell me a little bit about that?
For me, well, I'm a recovering pothead, alcoholic, and binge eater, or maybe I was an exercise bulimic, something in there. And for me, it was a way not to feel. Mm. A way not to feel and a way to feel comfortable. Alcohol was a social lubricant. Mm. Weed was help me chill out. Um, and, food was a distractor, a soother. Mm. Yeah. Dieting an obsession, exercise an obsession, but it was always not to feel for me.
So you know the experience of getting lost in food or numbing yourself with food. And you also know the experience of the shame that comes afterwards. You mentioned maybe exercise bulimic. So there was a part of you that was wanting to compensate after. Can you tell me what was or what is the process for you of learning to feel again and how that has and is changing your relationship with food and body?
Well, it was a process. I think my recovery started in 1993. Mm. And at that point, I was 4 years sober, clean and sober. Um, and so feelings were hard. Uh, and I think it took me I don't think I've binged since 2016, but, I didn't just stop because we can't not eat, and food is everywhere. Um,
Mm.
it was a process, a lot of therapy, a lot of coping, a lot of assertiveness, a lot of speaking up, um, boundaries, um, being present for myself, lots of tears, lots of anger, lots of journaling.
You spent a lot of time and a couple of decades really starting to get to know what the food was hiding for you and also learning to speak up in favor of yourself rather than just suppressing.
Right.
In some ways, I'd say my story is similar to yours. Like I've had the binge eating as well. I've definitely had quite a bit of emotional numbness and a process of moving through that. And it's interesting to see how that process and our stories lead us in different directions. So for me, I became a therapist. And I think that's something I was always drawn to. I think for a lot of people, they move in the anti diet direction or the direction of trying to change the societal standards that make it okay to comment about a person's body or to, like you were describing before, reject someone from a job because of their weight. For you, you became a bariatric psychologist. Why that? What draws you to the work?
Okay, so we'll back up. So when I got into recovery, there was no dieting, no more. I followed the intuitive eating path, the Janine Roth. If you're gonna overeat, pull your chair up to the refrigerator and do it. But feel it, understand it, learn about it, be gentle on yourself. So that was my kind of the anti, and I'm still anti-diet. I don't see them as helpful, and they don't work long term. Nutrition modification, I think that's important with health for health reasons. So when I started graduate school, I wanted to become a forensic psychologist. And then I quickly realized that I would rather work with folks who wanted help. And I had been out of my own therapy for several years, and my old therapist asked me to be her program manager for an IOP for eating disorders. And so in graduate school, my therapy practicum was at this IOP. Mm, And that's where I got on the path to becoming an eating disorder treatment specialist. And so that's the path I went down. And that's what I did. In the state I currently live in and the towns that I have lived in, I have been the only trained and experienced expert on eating disorder treatment. Mm. And so to back up a little bit to when I was working at the IOP, our program was approached by a bariatric surgeon who wanted us to develop an IOP program for folks who had eating disorder, eating problems before bariatric surgery to help them get prepared so they would be successful. So I helped develop that program. And we had a psychologist who was doing psychological testing. Her data was my dissertation data, which was great. I didn't have to do the data collection, just the analysis. And and so that's how I got involved in the bariatric world, was helping folks before surgery. And so when I went on my internship, I was the eating disorder specialist in my internship, and same with my postdoc. And when I got out of postdoc, I went into private practice, and I went to a bariatric seminar. And after the seminar, I talked to the surgeon and I said, "Hey, are you looking for someone to do your evaluations?" And he says, "Yeah, we are." And it turned out that my mentor was also a bariatric psychologist. And so he mentored me and trained me on how to become a really good one. And so that's how I got into the bariatric psychology world back in 2008. And so I did both. I used to work a lot. I don't know how I did it, but I used to see, 15, 20 clients a week and do 2 to 3 evaluations a week, sometimes 2 in a day. I can't do that anymore. I don't wanna do that anymore.
It's a lot, yeah.
And so yeah, I was doing both worlds, and in 2020, both my parents died, it was COVID, um, I was burned out, and I lost the passion for doing therapy. And so I had and it didn't feel fair to therapy clients to keep working with something that I didn't have a passion for. Mm. And I had bariatric psychology and psych evals to fall back on. And so now I work a lot less, and that's all that I do. And, that's how I ended up where I'm at.
Do you experience yourself as the holder of almost contradictory viewpoints or modalities? Because it's so interesting for me to hear you because I've just heard you juxtapose so many different ideas and processes that I have never in my life seen put together in the same person.
Yeah, so what's your question?
Do you experience yourself as holding, um, conflicting or different viewpoints or belonging to groups that are often in conflict? Or do those kind of mold together for you more naturally?
Mm. So when I was really involved in the eating disorder world and I'd go into IADEP conferences and NEDA and all those things, bariatric surgery wasn't on the forefront like it is now. Um, and so it wasn't until recently, I don't know, it was maybe in the late, um, I don't know when it was, but um that I was involved in a eating disorder treatment and internal family systems, that's my therapeutic modality, IFS consultation group. And there are people in that group that were anti-bariatric surgery. And so it was really interesting to have those conversations. And they were like, "Oh, wow. I really see the importance of your work because I'm trying to help people, um, if people are gonna do this surgery, I'm trying to help people be in a good place for it, and then I do a really good evaluation. And oftentimes the folks that they see didn't get a really good evaluation, or maybe they didn't get an evaluation, and they didn't get, a good treatment plan before surgery, and that's maybe part of how they ended up where they're at, or
Yeah. Okay. The plot just thickened for me when you were mentioning IFS because I love IFS as well. And the key phrase is the no bad parts. So you're so deeply and have been, especially when you were in a, as a therapist and eating disorder treatment provider, and in your own experience using intuitive eating. I hear in all of that acceptance based treatment, no bad parts, welcoming all aspects of self, working with your body rather than against that, all of those kind of phrases. And yet, what you do on a day to day basis is more of a process that involves people modifying their bodies. Tell me how those two come together for you.
well, it's not that I'm promoting people modifying their bodies.
Mm,
That's what they wanna do.
yeah.
And so I'm a part of doing the best I can to help them to be, mm, successful, if that's the right word, to meet their goals. I mean, if it's their choice if they wanna modify their bodies, right? I mean, I'm not saying, "Oh, yeah, you should do that." Um, what I'm doing is, saying things like, "These are things you should consider. It would be good if you considered these things or worked on these things," or, "Oh, hold on, you these areas need some work before, you can proceed."
Yeah. So if I were to translate that into a value statement, would it be I'm here to support people on the path that they choose for themselves, not to judge that path or that process as good or bad or right or wrong, but to help them do it safely in an informed way and in a way that takes into account their social and emotional well being.
Yeah, yeah.
Mhm.
I mean, same as if a client came to me and wanted to go on a diet. I support them in, what they choose
Yeah.
and explore the parts of them that want that and the parts of them that don't want that, and, that internal struggle. you know?
Mhm. Yeah. So your underlying premise, and even though you and I are doing very different things, the underlying premise, which this I feel wholeheartedly as well, is very much one of acceptance and embracing the whole person. Where it's like, I respect the totality of who you are. And if for you in this moment, weight loss is part of that, it's not my job to say that's wrong or that's bad or you shouldn't do that. It's my job to look deeper with you at what's motivating that and what's working against you.
Yeah, yeah, well put.
Mhm. That makes a lot of sense. And I see a lot of people who feel like they're forced to choose between the two worlds, forced to choose between either doing eating disorder treatment and accepting their body exactly as it is, which means rejecting all of diet culture and any attempts to lose weight, or following the medical model, or maybe they've been told by a medical provider, you need to lose weight. So they feel like they're kind of given this choice between either I adopt this eating disorder, a thing that maybe feels better to me in some ways, or feels like it addresses more of my emotional well being, or I follow my medical provider and this other part of me that wants that. And I'm sort of forced to choose between the two. So what you're giving people is the possibility of being able to hold both of those sides at once.
Yeah, I think so.
Hmm. Tell me about the evaluation process. What are you looking for?
Mm. What I'm looking for or what I'm looking to rule out are active addictions, alcoholism, eating disorders, severe symptoms of PTSD, anxiety, depression, emotional instability, like bipolar disorder that is uncontrolled. Because all of those things can get in the way of a person being adherent after surgery, being able to follow through on, what those post-surgical guidelines are. Also, and it's not just about following the rules and being a good person, good girl, or a good boy. These things can have devastating consequences to a person's health. And there's a higher risk of suicide afterwards. Um, Complications. If they're not doing what they need to be doing, there can be serious complications. There's a high risk of post-surgical alcoholism because the alcohol absorbs so rapidly and the blood alcoholics levels spike so quickly. It's very addicting, especially for folks who have a family history or a personal history. I had a therapy client die. I was with her days before on her deathbed, visiting with her because she couldn't get a handle on the alcoholism, and it killed her liver. And so it's very real. So, those are the things I'm looking for. And what I do is, before I meet with a person, I have them fill out a lifestyle inventory. And it's about diet and lifestyle, eating behaviors, mental health. Just it's like this 18-page questionnaire, and it gives me a lot of information. And I go through it when I meet them, and I ask all my follow-up questions, so I get lots of information. Um, but when I first meet with a person, they sit down in my office, and we do psychological testing. The testing might take some people an hour, sometimes it takes people 3 hours. It depends. Depends on how long it takes them to take tests. And then we go over the 18-page questionnaire. I review their test results with them, um, tell them what the tests say, see what they think. That's often a springboard for more conversation. more data collection. Then I do a clinical interview, and then I share my impression and feedback, and if there are requirements, I share those with them as well. And then after the report is written, they get a copy of the report. And if a person is currently in counseling, or is seeing a psychiatrist or a psych nurse for medication, I also request information from them just as a confirmation, or get some more information about the patient, because oftentimes patients are motivated to not be entirely forthcoming because they want surgery. They want desperately for their lives to change and to lose weight.
Okay. So you're looking out for comorbidities that might impact their ability to follow postoperative recommendations, and specifically their ability to follow those in ways that might compromise their safety. Would that be accurate?
Yeah, safety, um, whether it's medically or psychiatrically.
Mhm. Yeah. You mentioned earlier, almost in a very matter of fact way, I'm a gatekeeper. This is what my job involves. And you also mentioned that you left the therapy space because you started to lose passion for it. And you believe that when you're serving clients, it should be with your energy in it. What is it about this? Like, where is the life in the being a bariatric psychologist for you? What draws you to it? On the on the day to day as you're doing it now, what do you enjoy about it? What are the rewarding moments?
Mhm. When I'm meeting with someone, I mean, my appointments are really in depth. Some people would call them invasive, because I'm passionate about this. But when the light bulb goes on and people are like, "Oh my god, that's why I do that. I never thought about that. Oh, you have a good point." I get the spark that what I'm doing is really helpful. Mm. And, I get emails from folks that say, "Thank you so much. It was a really hard appointment, but thank you for taking the time with me and helping me to see these things, and I found it really beneficial." Um, so I guess in essence, I'm really good at what I do. Um, I mean, we all like being good at what we do, and I think much of the time I make a difference
Mhm.
and help people have hope when they didn't before.
So the process you enjoy and the process that you're good at is going really deep into a person's story and understanding what the patterns are underneath it. And that's where you see those light bulb moments when you're doing this really, really thorough assessment. And somebody's like, wow, I learned something about myself that I didn't know before. And now I understand all of these different things that I was struggling with.
Mhm. And how it ties into, how they got to where they are.
Yeah.
Not in a blaming oneself sort of way, but just insight.
One more question that feels important just currently is GLP-1s. How are they affecting
No.
your practice?
They're killing me. Bariatric programs across the United States have a significant decrease in people wanting bariatric surgery. All bariatric programs are seeing this. And so that has decreased the frequency of my referrals. Even one of the out-of-state, referral sources that I was getting a lot of referrals from, they, like, dried up, so I sent the coordinator an email and I said, "Hey, is there s is everything okay with us? Are we okay?" Um, and she said, "Yeah, we're great. We love you." And we're just not getting a whole lot of referrals to send your way. And then what I see with people in my office that may be on and I'm this is my experience, and it's at the risk of being generalizing, but it's just my experiences. GLP-1s are the magic cure for a binge eating disorder, but they don't do the work underneath. And so for some folks, they can make the change, the behavior change, and it can stick. But for many, once they stop the food noise, the binging, the grazing, the food addiction, all those behaviors come back, and so does the weight, and then the shame tenfold. And then they're like, okay, I give. It's time for bariatric surgery. Um, so we're seeing people coming through in that way. And I caution people, like when they come to me and they're on a GLP-1 and, they were a binge eater beforehand and now they're not. I have a very serious conversation with them about potentially what could happen when they stop. And whatever is under there, they need to address. If they don't, they may struggle after surgery.
Yeah. It sounds like that would be a challenge equally between GLP-1s and bariatric surgery because they're both medical procedures.
Right?
If bariatric psychology theoretically became obsolete because GLP-1s give a less medically invasive way of achieving the same thing, what would be your reaction? How would you feel about it?
Well, I'm not terribly far from retirement. Um, um, you know, if people find something that works for them, I think it's great.
Yeah.
Um, yeah.
Yeah. Perhaps your statement that I'm not far from retirement makes this question obsolete, but if you weren't doing bariatric psychology, what would you be doing? And this really goes back to the question about the specific parts of it or the aspects of it that you're most passionate about.
Well, I might look for another passion in assessment. I won't go back to doing therapy unless I find, that spark happens again in me. Um, I have toyed with the idea of doing ADHD assessments, getting up to speed on learning about those and how to do those well and helping people with that. I could probably be as busy as I wanted to be. There are many doctors who are looking for someone to do such evaluations before they'll prescribe medication. So that might be something, that is something that I consider at this stage, that I haven't, pulled the trigger on moving forward with that.
Yeah. So the passion for you again is in evaluation.
The passion is in bariatric evaluation. I also do a handful of eating disorder evaluations, but it's, the same kind of thing. It's the same evaluation. Uh, Evaluating someone for various types of eating disorders and, giving them a treatment plan.
Mhm. What are your feelings? And this brings us back to where we started. What are your feelings about being in the position of gatekeeper?
It's changed over time. Um, Used to make me really anxious because I think I had parts of me that were really insecure. Mm. But now not so much. Um, Yeah, and when someone gets a yellow light, I always tell them, you can get a second opinion, you know? Um,
Yeah. What was the content of the anxiety in the beginning when you were anxious about it?
am I doing the right thing? There's a part of me, am I making the right decision? Am I making the right decision? This person is really upset with me. Oh my gosh, did I say something wrong or do something wrong? Or, and I would have to, look back over it and talk myself through it because everything was fine, or consult. I've done a lot of consulting with other bariatric psychologists, and I still do. Um, so I guess my feelings about being a gatekeeper is it's what I do. I'm just trying to help.
Yeah. Would you say if you're confident in the integrity of your own decision, you're a person who's okay with having people upset at them?
Mhm. Yeah.
Yeah.
It's taken a long time. And there's still a little part of me that, like I'm sitting with a person in an evaluation, and I can tell how it's going, and there's something in the back of my head, or a part of me that's like, "Oh my god, is this person gonna, blow up at me, or, what are they gonna do, or how they, and um but that part of me is a lot quieter and smaller, and oftentimes, um, just it doesn't come to fruition, and so with experience, um, I'm far less anxious about what I do, and to have surgical programs that really value what I do and appreciate all the people that appreciate that I'm not afraid to give folks a yellow light, um, because ultimately, it helps everyone.
And that's where there's also another kind of emergence between what you do and the eating disorder recovery world, where I hear a lot of people complaining about how they feel like with medical procedures and specifically weight loss medical procedures, medical providers will sell the benefits without really giving the person a real picture of the risk. And that is a lot of what you do.
Yeah.
Thank you so much.
Mm, yeah. I wanna say for the people who get the green light, they often get recommendations, like I'll say, you if you went to therapy, you'd have things to talk about. After surgery, keep an eye out for this or that, or really start work on this a little bit more before surgery. So, it's not just a green light with nothing, they get takeaways as well.
Yeah. Thank you so much for coming on.
You're welcome.